So thank you again for this webinar, and it's a delight and a pleasure to join your group as usual, and I look forward to a very interesting case discussion at the end of this. So I'm going to talk a little bit today about what's happening in the world of AL amyloidosis, touch a bit about what might be happening in POEMS, and then end with a short update on what's going on in Waldenström's macroglobulinemia. The main focus of this talk will be treatment of AL amyloidosis, particularly monoclonal antibody-based treatment in AL amyloidosis. So as you're aware, AL amyloidosis is typically a low-grade plasma cell dyscrasia. Most patients don't have multiple myeloma. They have smoldering myeloma or MGUS, and the treatment has always been directed at the underlying plasma cell clone. This is our current treatment algorithm for AL amyloidosis. As you can see, patients are risk stratified based on whether they have low-risk disease, no evidence of cardiac involvement, high-risk disease, where they may have very severe cardiac involvement, and then most of the patients, about 60%, would fall into the intermediate-risk disease, where they have some degree of cardiac and or renal involvement. And treatment is typically centered around a bortezomib-based regimen, which has now become our standard of care. However, other types of treatments, such as stem cell transplantation, may be suitable for some patients, but we are slowly moving away from doing upfront stem cell transplants to a more or less extent. The key in amyloidosis is to assess responses very quickly and change therapy if the patient hasn't responded within the first few months of treatment. And again, the treatment at relapse is not desperately different from what happens in patients with multiple myeloma. One would typically try to use the same treatment if the response and the time to relapse was very long. But if the patients have relapsed within a couple of years of the initial therapy, then one would ideally want to go for a non-cross-resistant regimen. So if they had a proteasome inhibitor at the beginning, you would want to use an immunomodulatory agent or a combination or a triplet, depending on what drugs are available. A small proportion of patients with AL amyloidosis, about 10%, will present with significant neuropathy, where bortezomib or ixazomib, the typical proteasome inhibitors we would use up front, are not suitable. And these patients are then typically treated with a lenalidomide-based regimen, which can be challenging. Sometimes we use it with cyclophosphamide. We have recently reported a small case series of once-weekly carfilzomib in these patients, which can be very safely used. And of course, we have daratumumab, which we will talk about a little bit more later. So patients with low-risk AL amyloidosis are candidates for an autologous stem cell transplant. This has been a treatment for AL amyloidosis since it was first described by the Boston group in the mid-90s. And these are the criteria that we would use for selecting patients. No significant cardiac involvement, young, good performance status, good renal function, good systolic blood pressure, absent of clinically meaningful effusions, no significant bleeding. We recently looked at our UK experience over 25 years of stem cell transplant. And as you can see very well, that the mortality in our early cohort was quite high, about 20%. It's now decreased. And in the later cohort, we have a very small treatment-related mortality with a very good survival. And when we are coming up to 4 or 5 years, we have over 80% patients still alive. And patients who get a complete response, which means that the monoclonal protein is essentially eliminated, the survival is even better. Nearly at 5 years, you're having 90% plus patients alive, whereas patients who get less than a complete response don't do so well. And lately, there have been some good studies from colleagues in the United States where they have given adjuvant therapies for patients who don't get a complete response after an autologous stem cell transplant. Our standard of care in the UK and in most places worldwide still remains cyclophosphamide bortezomib test, CyBO-D or VCD as we call it. And this was the paper we published last year where we reported our experience with just over 900 patients treated with CVD. On an intent to treat basis, the responses look moderately good because we have a lot of deaths early on. But overall, we find that about 60 to 70% patients will respond and just around 60% patients will get a very good partial response or better. What struck us when we looked at this data was that patients who get a complete response often don't require treatment for a very long time. So patients who had a complete response, when we are going up to 5 years, the median hasn't been reached. And same is true for patients who get a very good partial response. This essentially means that with this treatment, we are achieving remission rates and response rates which are not dissimilar to what we have seen in the past with autologous stem cell transplant. We are about to publish a paper where we've compared head-to-head autologous transplant with this combination. And really, we can't show a substantial difference in the outcomes of the two groups of patients depending on the patient selection. So watch this space, but certainly we may have to reevaluate where autologous stem cell transplant falls in AL, given that these treatments can achieve very good and very prolonged responses. Some of the newer combinations which have been studied, we recently reported our experience with the use of ixazomib, lenalidomide, dexamethasone in this patient. We use it in relapsed refractory setting, patients who have relapsed after initial bortezomib-based treatment or even some lenalidomide-based treatments. And what we can show is that the response rates are actually fairly decent. About 50% of the patients will get a VGPR or better, which is much superior to what we see with just single-agent lenalidomide. The treatment is fairly well tolerated, and patients can stay on treatment for quite a long time, and the responses deepen over time. This is certainly one of our favorite treatments for patients with relapsed disease following upfront bortezomib-based treatments. Responses are good. Patients are doing better. So why do we need newer treatments? Our challenge is that the organ responses still remain really slow. Often don't happen for a year, sometimes 2 or 3 years. And even with CVD or IRD, as I just showed you, the deep responses, CRs, the very low light chains, which we have shown to be important for survival, are only seen in less than a third of patients. Patients with cardiac AL will still die even if they get a clonal response. And as you can see here, patients who've got stage 1 disease, stage 2, stage 3, this is bortezomib-treated patients, the outcomes are still poor in the patients with advanced cardiac involvement. And patients who present with advanced stage renal disease, and this is some data from our European colleagues, showing that a high proportion of these patients, up to 60 to 70% of patients in stage 3 and about half the patients in stage 2 will progress to dialysis or end-stage renal failure. So clearly we need to do better. Our aspiration really is to use monoclonal antibodies, since chemotherapy still remains toxic. We've got 2 separate possibilities for targeting. We've got the plasma cells, and we've got the whole host of monoclonals developed for myeloma treatment that we can use in amyloid for plasma cells. Daratumumab is the main one. And then we've got antibodies which we can use to accelerate clearance of amyloid protein. NEO-001, anti-SAP were 2 programs which were closed. This is a new antibody. I'll talk a little bit more about this later, called KL101, which is likely to come into clinical trials this year. And then there are a few others which are at various stages of development. And then on the anti-plasma cell front, the GSK monoclonal antibody, belamaf, has just been licensed for relapsed myeloma, and we are about to start a phase 2 trial in AL amyloidosis. The biggest advantage of daratumumab over standard treatments is that it's non-overlapping. We do see depths of responses, and it appears to be reasonably well tolerated. A number of studies have been reported over the last few years in patients with relapsed refractory disease. This is just one of those studies from the Boston group, showing that in patients with relapsed AL amyloidosis, we are seeing VGPRs and PRs in nearly 90% of the patients, and time to response is quite rapid within the first 3 weeks, and best responses are achieved within 3 months. And this seems to translate into cardiac and renal responses in about half the patients who are treated, which is a great advantage in this patient population. One of the things which has emerged in AL is that translocation 1114, which occurs in about 50% of patients with AL amyloidosis, is associated with poorer outcomes when treated with bortezomib, and that's always worried us. This was a study from the German amyloidosis group, which reported patients treated either with dara-bortezomib dex or just dara-dex, and were able to show that the time to progression and overall survival appeared to be fairly similar when using this combination. Maybe dara abrogates the bad effects of D1114 in the setting of AL amyloidosis. They also showed something quite interesting, that patients who are treated with daratumumab but have got significant renal disease tend to have a much shorter time to progression. Patients who have an albumin-creatinine ratio of more than 220, i.e. those who are significantly nephrotic, tend to have much shorter survival compared to those patients who are less nephrotic. And you can see across the board, patients who have high light chains and who have a high albumin-creatinine ratio, the response rates are much poorer, the green being the deep response rates. They also were able to show that daratumumab is detected in the urine. We know that there is overflow immunoglobulin in the urine in these patients, and you can certainly detect it. And we need to understand the kinetics of daratumumab in these renal patients to be able to use it better. And this was their overall survival stratified by presenting light chains and proteinuria. Patients who had low light chains, low proteinuria did the best. Patients who had high light chains, high proteinuria did the worst. So clearly, single-agent daratumumab, even in combination with bortezomib, may not be the answer in the renal patients where we are not seeing the deep responses that we see in the cardiac and the other groups of patients. Moving on to daratumumab in the frontline setting, there's a phase 3 trial which is completed, and this was a patient that we treated just at the beginning of the phase 3 clinical trial. This was actually a patient who was from southern India and who received this treatment in India, not in the UK. Presented with multiple myeloma, 52% plasma cells in the bone marrow, very high NT-proBNP of nearly 14,000 at presentation. As you remember, with patients presenting with this NT-proBNP level, median survival is 4 months, and serum free light chain of 12,000. She started treatment with weekly Cybo-D and daratumumab protocol. On day 8 of treatment, her light chains were down to just under 100. By day 15, they were about 30. And by day 22 of treatment, the light chains were normal. And on the first day of the second cycle, her light chains were under 20. Her NT-proBNP, which is a marker of cardiac response, initially seemed to creep up a little bit, but then quite remarkably, by end of the first month or second month, started dropping and has continued to drop. At a year, this patient is now MRD negative. She was bedbound in a wheelchair when she came to see me in London. And now about a year later, she's back full-time working as a dentist. So this was the Andromeda study. Looking at Cybo-D versus Dara-Cybo-D, initially the run-in phase was 28 patients for safety, and then the randomized phase was just around 360 patients. This run-in data has now been published in Blood, which shows that patients in the early run-in cohort, the response rates were nearly 96% with a complete response rate and a VGPR rate of 82%. The deep responses, DFLC of less than 10, the difference between the involved and the uninvolved free light chain was seen in 71%, very deep responses in this group of upfront patients. And this translated into organ responses in a very high proportion of patients. About 70% patients had a renal response and nearly 60% patients had a cardiac response. This is quite uncharacteristic in amyloid. We have rarely seen these deep responses this rapidly with other treatments. This was data which was presented on the main clinical trial, the randomized portion, where 195 patients were treated with Dara-Cybo-D, 193 with Cybo-D. And again, you can see that there is a very significant difference in the complete response rates on the Dara-Cybo-D arm compared to the Cybo-D arm. And the time to response was rapid. The median time to VGPR with Dara-Cybo-D was just 17 days. Progression in amyloid is challenging to assess, and this trial used a complex progression endpoint, which was heme progression, end-stage renal failure, cardiac failure, or death. And again, the Dara-Cybo-D arm appears to be superior to the Cybo-D arm in this clinical trial. Moving away from daratumumab, belamaf is a new GSK toxin-conjugated BCMA monoclonal antibody. It appears to be very effective in patients with heavily pretreated multiple myeloma, and we are very much hopeful that this drug will also be effective in AL amyloid, whose plasma cells express BCMA, probably at a marginally lower level, and we are planning to start a phase 2 study quite soon. But the key really in amyloidosis is to remove the protein. We know that in animal models, this is a liver biopsy from an amyloidotic mouse. And you can see that with monoclonal antibody treatment, the amyloid protein goes away within a couple of weeks. A variety of trials have been done thus far. We've completed a phase 1 program for anti-SAP and NEO-001. A number of phase 2 trials were on, some of which have now been closed. NEO-001 was the first one which went on to phase 3 clinical trials. It is a monoclonal antibody directed against the misfolded amyloid fibrils. And you can see on this panel that the macrophages are ingesting the amyloid fibrils when incubated with NEO-001 compared to controls. The VITAL study was a study which was comparing Cybo-D treated patients with or without NEO-001. And in the main part of the study, it appeared to be somewhat disappointing that there was really no significant difference in survival for patients who were treated with NEO-001 compared to standard of care. But when we did some subgroup analysis, it appeared that patients with advanced cardiac disease seemed to do better with NEO-001 compared to placebo. This is an intriguing observation, and the trial data is being reanalyzed to see whether there may be some merit in considering this in a further group of cardiac patients. Dual monoclonal antibody therapy, which is the holy grail in amyloid, where we can avoid chemotherapy, was reported by the Boston group, where they had some patients on the VITAL study who also received daratumumab. There was no interaction, the response rates were high, and 7 of the 8 patients had a cardiac response within 3 months of combined treatment. And maybe this is the way forward. We reported a combination of an SAP depleting drug and an anti-SAP antibody, and I've probably shown these slides before, showing good regression of hepatic and splenic amyloid deposits. We went on to do a phase 2 clinical study, but unfortunately, we ran into some problems with significant toxicity with this program and did not really see a great deal of efficacy, mainly because of the problems, and this trial and program has now been terminated. There's another antibody called KL101, which is an antifibril antibody, and they reported a phase 1, phase 2 study some years ago now showing good responses in cardiac and renal patients. And they also looked at cardiac functional improvement and were able to show this longitudinal strain, which is a marker of longitudinal cardiac function, to improve within 12 weeks of treatment. When we look at patients who were not treated with monoclonal antibody in a larger cohort of retrospective patients, we find that the time to response is over a year in this setting. So it's quite dramatic. And if this is now starting phase 1 clinical trial, so phase 3 clinical trials. The other type of amyloid, which is becoming increasingly common, is transthyretin amyloidosis of the wild type. A number of treatments have come along to stabilize this TTR protein, but removing the protein really is where we need to go. PRX004 is another antibody from the Prothena group, which binds to the misfolded TTR and may help to remove the TTR protein. A phase 1 clinical trial has completed accrual, and we await the results. The Japanese have reported another antibody called T24, and in the preclinical models, it binds very nicely to the TTR deposits, and preclinical work appears to suggest that it appears to be safe in animal models. We look forward to seeing the phase 1 program with this quite soon. There is a company called Aurora Bionic who have got an agent called P14, which binds to amyloid deposits. They've done PET scans. You can show heart uptake in the heart, the kidneys, the liver. And this peptide can then be conjugated to an antibody. So this is the peptide which binds to the fibrils. This is the antibody portion which can bind to the amyloid. This will then recruit the macrophages which will opsonize the amyloid fibrils. This drug is now starting phase 1 clinical trials very soon. The key really for us is that the macrophages are what will eat up the amyloid fibrils, and the same program has come up with a very novel concept. Very similar to CAR T cells, they have now developed a preclinical model of a CAR macrophage where there is an amyloid binding peptide with a spacer which is activated on the surface of the macrophage. And rather than using a monoclonal to target the amyloid fibrils, one could, in theory, just use the macrophage to directly clear amyloid deposits. Fascinating area, and we await to hear more in the near future. There is another company called Proclara, which has used a bacteriophage. Bacteriophages have got these capsid proteins which can bind to fibrils, and that's how they gain entry into bacteria. These capsid proteins can also bind to amyloid fibrils, and they have basically conjugated the capsid proteins with human Fc and used this to target amyloid deposits. They've completed a phase 1 program, and we await to see where this company goes with their phase 2 program. I think I'll stop with amyloidosis there and switch gears to POEMS syndrome. Neuropathic complications in monoclonal antibodies are quite common. POEMS is probably one of the best defined syndromes within this setting. You're well aware of the criteria for diagnosis of POEMS syndrome, and I won't go through this in very great details. But as you remember, there are 2 mandatory criteria: polyneuropathy and monoclonal proliferative disorder, which is almost always lambda. Then we have sclerotic bone lesions, Castleman's disease, and high VEGF, and a whole host of other factors which define the syndrome in its own right. But one thing is emerging, that about 10 to 15% of patients who present with POEMS-like syndrome may not necessarily satisfy all these criteria. Typically, may not satisfy this criteria of a monoclonal anti-plasma cells or high lambda light chains. And this is where it comes. Multicentric Castleman's disease may be associated with a POEMS-like phenomenon. We've always known that if you biopsy an organ or a lymph node in POEMS, you may see Castleman's-like lesions and your follicular lymph node hyperplasia. But now a Castleman's variant of POEMS has been described, where 30% may have Castleman's histology. These are patients who present only with peripheral neuropathy. Patients who have a typical plasma cell clone are characterized as classical POEMS, but those patients who present with a lot of other features of POEMS syndrome, who have presence of Castleman's disease, but don't actually have presence of a monoclonal plasma cell proliferation, are now classified as a Castleman's variant of POEMS syndrome. In these patients, the neuropathy is very subtle. It's axonal and demyelinating. But if you look at the nerves on electron microscopy, in normal POEMS syndrome, the typical feature is that it looks like onion rings. The myelin spacing is massively increased. In the Castleman's variant, this doesn't happen. In classical POEMS, VEGF is very commonly the elevated cytokines. In Castleman's, IL-6 is often the aberrantly expressed cytokines. And these patients will almost always have a significant polyclonal hypergammaglobulinemia. So if you have a patient who presents with a POEMS-like syndrome, who has got Castleman's in the background, then don't discount it if you cannot document the presence of a monoclonal plasma cell disorder. Patients with POEMS syndrome need fairly detailed assessment, and this is a table taken from Angela Dispenseri's review of POEMS syndrome in the ASH education book. And it basically tells us what we need to do for follow-up. A number of things have to be done when we see patients regularly. And then patients, once they've been treated, a follow-up every 1 to 2 years, where we measure their VEGF levels. They will have 24 urine protein electrophoresis, repeated bone marrow and nerve conduction studies as appropriate, but more importantly, echocardiogram, pulmonary function tests, and skeletal lesions, including a PET scan as appropriate. The treatment for POEMS syndrome, the basis hasn't changed for a long time. And the basis remains very, very simple. If you can document clonal plasma cells on an iliac crest biopsy, i.e. at a site remote from the sclerotic lesions, these patients need systemic treatment. If these patients don't have plasma cells but more than 3 bone lesions, they still need systemic treatment. But patients who have a few isolated sclerotic bone lesions can be treated with radiation at the site of the bone lesions, and then they continue with assessment. Patients who don't have clonal plasma cells or who are very sick will require vigorous supportive care. Patients who are treated simply with radiation, this was an update from the Mayo Clinic group published a couple of years ago now, and they had 90 patients who presented and treated with just radiation. The 10-year overall survival in this group of patients is very good at 70%, and the time to disease progression at 6 years is 62%. So this is an important treatment for patients with POEMS syndrome who have isolated sites of disease. The mainstay of treatment for patients with POEMS syndrome tends to be systemic treatment. This was a very large study reported by a group in China where they looked at just over 200 patients. And the 3 main treatments which are used for POEMS are an autologous stem cell transplant if the patient is fit, lenalidomide dexamethasone if the patient is not that fit, and a number of groups, particularly the Chinese, have used melphalan dexamethasone where access to lenalidomide was challenging. And what you can see, the red bar is stem cell transplantation, is that the complete responses, CRH, which is hematological, and CRV, which is the VEGF response, is highest in patients who receive a stem cell transplant. The overall response rate is not very significantly different between all the 3 groups. The overall survival in this patient group was reasonably good, but in patients who were treated with ASCT or Lendex, the time to progression and overall survival was not that different in the long-term follow-up. So although complete responses are good, the time to relapse may be shorter in the Lendex. Overall survival with all of the treatments appear to be reasonably good as long as you can get a deep response to treatment. So Lendex or ASCT are reasonable upfront treatment for patients with POEMS syndrome, depending on the fitness and access to therapy. There are case reports which are now emerging for use of daratumumab or daratumumab Lendex, and there are about 6 or 7 cases which have been reported. Some of them showing rather rapid responses, an occasional one showing some unexpected side effects. I'm sure this agent will have a role in treatment of POEMS syndrome, but further data is awaited. Counterintuitively, proteasome inhibitors also appear to be effective in this disease. This was a report from the Mayo Clinic group where they reported a small number of patients, some even treated with bortezomib, 1 with carfilzomib, 1 with ixazomib. And 3 of the patients of these 12 had a CR, 50% normalized their VEGF level. 2 patients had improvement in neuropathy, but quite interestingly, only 2 patients had to stop treatment because of worsening neuropathy. And we often run into patients with POEMS who are now relapsing after initial treatments, and a proteasome inhibitor-based treatment may, in exceptional circumstances, be a possibility here. Switching gears again, moving on to Waldenström's macroglobulinemia. It's a disorder which straddles between our lymphoma colleagues and the plasma cell dyscrasia teams. Patients have an IgM monoclonal gammopathy. Patients may progress to have a greater degree of bone marrow plasma cell infiltration with lymphoplasmacytic cells, more than 10%. Where we have small ring Waldenströms, the IgM level will creep up. Or then you have patients who essentially have symptomatic disease, which is symptomatic Waldenström's macroglobulinemia. This then has a differential diagnosis with this very rare entity of IgM multiple myeloma. And the availability of the MYD88 screen has allowed us to make this differentiation much easier. IgM myeloma will almost never have MYD88 mutations and almost always have T1114 or one of the other IgH translocations. These patients will also have evidence of bone disease, which is very uncommon in patients with Waldenström's macroglobulinemia. Patients with IgM amyloidosis can have either Waldenström's macroglobulinemia with MYD88 mutations, or they may have an IgM secreting plasma cell disorder with IgH translocation. So these could be either of this, and the treatment may vary depending on which of these two we think you've got. And then the closest differential diagnosis, which often complicates our thinking, is splenic marginal zone lymphoma. If this particularly has significant plasmacytic differentiation, there may be a substantial overlap in the differential diagnosis for Waldenström's. Again, the MYD88 will help us to differentiate. The overlap is typically with MYD88 negative WM and MYD88 negative splenic marginal zone. The immunophenotype may help. CD103 is positive in some patients with splenic marginal zone, is almost always negative in WM. PAX5 is more often positive in WM, more often negative in splenic marginal zone. Hyperviscosity, very high IgM are uncommon in splenic marginal zone, whereas they can be variably present in patients with WM. The clinical algorithm for WM it varies depending on which country, which set you look at, and it has been changing based on our understanding of the genomics. This was an algorithm which has come from the French WM group, from Véronique Leblond and colleagues, where they recommend rituximab-based therapy for patients who simply present with neuropathic features and an IgM paraprotein. For patients who present with hyperviscosity or need a rapid response to treatment, they would consider plasmapheresis and then consider treatment with bortezomib or bendamustine. Rituximab is deferred because of the risk of rituximab flare in about 40% of the patients. Other symptomatic patients, they would consider these various combinations, DRC, R-Benda, or BDR. And in patients who are very frail, ibrutinib has been fairly transformative as a well-tolerated but often very effective treatment. Patients who relapse, if they have response for more than 2 years, then retreatment can be considered, except for ibrutinib. Patients who are eligible for an autologous stem cell transplant, you would avoid purine analogs, and bendamustine or ibrutinib remain good choices. And for purine analog ineligible patient, of course, have all the other options. Patients who relapse early, who have significant or rapid disease progression or do not respond to first-line treatment, may be candidates for an autologous transplant or rarely an allogeneic transplant. The two mutations which have now characterized the disease landscape of WM are MYD88, which has turned out to be a disease-defining feature in nearly 80% of the patients, and CXCR4, which is seen in about a third of the patients. And you can therefore classify patients into three different groups: both MYD88 and CXCR4 mutated, MYD88 mutated CXCR4 wild, and MYD88 and CXCR4 wild. One of the debates is whether the MYD88 CXCR4 wild are genuinely patients with WM, or whether we are looking at a different lymphoid disorder in its own entity. This was a report from Steve Trion and his group, who looked at the MYD88 wild type WM, where they show that patients who are MYD88 mutated or CXCR4 mutated have better outcomes compared to patients who are both wild types, and these patients appear to have a higher risk of transformation to high-grade disease. And the other critical feature is that targeted treatments, such as ibrutinib, tend to have poorer responses in the wild-type patients. So targets for therapy with WM is now dominated by the BTK inhibitors, which of course is the disease-defining feature of this condition. There are studies going on with antibodies to CXCR4. There were some treatments which appeared to be very promising a few years ago, but they have now fallen out of fashion. And then we have got venetoclax, the BCL2 inhibitor, which also seems to be highly effective in patients with WM. This was one of the pivotal studies reported by Timopoulos and colleagues, where they showed placebo versus rituximab and ibrutinib versus rituximab, showing that the response rate was significantly better a number of patients showed complete and very good partial responses, substantially superior to rituximab placebo. I don't think there's any doubt anymore that ibrutinib or ibrutinib rituximab is a treatment for WM. One of the major criticisms of the studies was that there was no ibrutinib alone arm to show what was the benefit of adding rituximab to ibrutinib. And depending on the patient, depending on the risk of infections that you may perceive, there may be a call not to add rituximab to ibrutinib in this group of patients. The Boston group reported this very interesting result. What they were able to show was patients who were treated with ibrutinib, the changes in IgM level and the improvement in the hemoglobin level was very different. Patients who had CXCR4 wild type and MYD88 mutated, this is about 40% to 50% of all patients, had the best responses. Patients who had a CXCR4 mutation had intermediate responses, and as I said before, the wild type patients had the worst responses. And of course, hemoglobin improvement is opposite to what you see in reduction with IgM. And this has certainly led to a significant perception that these patients would definitely benefit from treatment with ibrutinib. Maybe these patients would not benefit to such a degree. I think this holds true for the wild type patients. But what the Boston group then went on to show that if you continue with treatment with ibrutinib in patients who have CXCR4 MYD88 mutations, and you've got the three groups again, the responses occur over time. The patients who are CXCR4 wild type have fairly rapid responses, which deepen over time. But patients who have a CXCR4 mutation respond more slowly, but continue to hold their responses. So having a CXCR4 mutation is not necessarily a deterrent to treating these patients with ibrutinib. Second generation BTK inhibitors are now coming along. Acalabrutinib, recently approved for treatment of mantle cell lymphoma, was reported by Roger Owen and colleagues from here in Leeds, showing responses in both upfront and relapsed refractory patients, including very good partial responses in a high proportion of patients. The duration of response appears to be very good, with 90% patients still in response at 2 years. BGB311 or zanubrutinib reported again in a variety of lymphomas, showing significant and deep responses, and a clinical trial comparing two different doses of zanubrutinib is now ongoing, and we await the results of this. Venetoclax, the BCL2 inhibitor, was reported by Steve Trion and colleagues at EHA a couple of years ago, showing deeper responses than what we've seen often with ibrutinib in a heavily pretreated group of patients. Overall response rate of 80% with a PR or a VGPR rate of 30%. One of the things which certainly struck me with venetoclax, which is very different to what we've seen with treatments on ibrutinib, is that there was a rapid reduction in the bone marrow infiltration, which in venetoclax-treated patients tends to be, in ibrutinib-treated patients tends to be very slow. And clearance of the bone marrow in WM in this setting is quite important. And a clinical trial combining ibrutinib and venetoclax is now ongoing at Boston. Carfilzomib may have a role in this patient, and certainly this was a study now reported quite a long time ago by Steve Trion. We have not seen updated results, with 17% or better overall response rate using a combination of carfilzomib Lendex, carfilzomib rituximab dex, particularly in neuropathic patients. So the new algorithm for WM, asymptomatic patients continue with watchful waiting. Symptomatic patients with MYD88 mutation CXCR4 wild type, one may choose ibrutinib as a treatment of choice. If accessible, Benda-R remains an option. Those with mutated patients, you need a rapid response. You probably wouldn't go down the ibrutinib route because we know responses are slow and delayed. These patients are best treated with a bortezomib-based combination or with bendamustine. Patients who are wild type, probably ibrutinib is best avoided in this group of patients, and they're best treated with rituximab, bendamustine, or a bortezomib-based combination. So this was my last slide. A quick whiz through these. Thank you very much for your attention. And it was an unusual thing to speak on Zoom. And then I hope that when this situation stops, I'll be able to fly back to India and be with you. Thank you.